if you don't listen to Sergio's podcast, one thing he loves to do at the end, especially interviews, is talk about what book you're reading. So I wanted to ask you, what book are you reading? And tell us, and it can't be Marcus Aurelius. Tell me a different book.
For sure.
This is On Call.
Wow, this would be really cool to just wear scrubs all the time. Then you don't have to think about what you're going to wear to work.
Joke is awesome.
We're here to answer your questions.
We can sit down and discuss all. Wait, I gotta go. I'm on call.
Wait, you're on call? I thought I was on call. Hey, everybody. Welcome back to an episode of On Call with April and Alicia. I'm Alicia.
I'm April.
And I'm Sergio.
Hey,
we have a guest
in the call room. Welcome, Sergio.
Thank you. Thank you for having me.
Yeah, welcome. So Sergio is Dr. Sergio Zanotti. He is our Chief Medical Officer of Critical Care here at Sound. So Sergio, we're excited to have you.
I'm excited to be on the podcast today and talk about what I think is a very important topic.
Awesome. Sergio is like a very famous podcast host from Critical Matters. So we're excited to have you here for you to share all of your knowledge with us and with our listeners. So that's awesome. And thank you. Before we get into the episode, April, Sergio, just to check in, how are you guys doing? April, how are you?
I'm good. We are like officially into the fall weather, which I know you hate, but I absolutely love.
Absolutely do. You're absolutely right. Sergio, everything going well? You're in Texas. Houston is what you said?
I'm in Houston. It doesn't feel like fall yet, but it's beautiful outside and I'm doing very well and very excited. I'm going to see my granddaughter this weekend.
Aww.
So it's I can't wait for it to be Friday afternoon and fly out of here.
How old is she now? She's little still. Yeah.
4 months.
4 months. Aw.
That's lovely. I've got not much to share. Well, actually, no, I'll take that back. I've got a little bit to share. You know, we've been hit with some pretty significant weather. Helene, Milton. So actually, I think I spent the last couple of weeks just working on some disaster relief efforts for Sound to kind of help some of those areas. So that's kind of been morbid, a little sad to see what some of these people are going through, but I'm really excited to see that Sound's responded to that and that we've been able to work on some teams on the ground there. So that's really all I've got new, Abe.
Yeah, it has been really hard, for a lot of people. So it is good that we are able to help those that we can. So yeah, I agree.
Yeah, we'll hopefully have some like really triumphant stories come out of that and just like the heart of humanity. I love to see that. I love to see the outpouring of interest just even from our teams when we connected with Annie, and we're really passionate. I obviously not in those affected areas, but it affects us all as humans. So it's been just lovely to see the outpouring just from our clinicians, from our business development, from everywhere in Sound. Like, do we donate? Can we be boots on the ground? What can we do? So it's really been, it's been lovely. It makes me love where I work and what I do. So I've been really excited about that.
Yeah.
So
sure.
I was not any fun Weather Channel stories anymore because things kind of got real. So there's that. But we've got a really packed episode here today. So I want to get into Let's Break the Ice with Sergio before we announce what we're going to talk about. Sergio, as you know, we do a segment called Let's Break the Ice. It's just kind of a way to warm up, get to know a little bit about you that's not so clinical. So April and I are just going to ask you some rapid fire questions and you get to answer honestly. April, you want to start?
Sure. I'll go first. So Sergio, my tradition is to ask something about food. So
always
in keeping tradition, and we're coming up on Thanksgiving. So what is your favorite dish at Thanksgiving dinner?
Excellent. That's a great question. So I grew up in an Italian family and food was a centerpiece of my childhood. Very important to have, multiple plates and for every season or holiday, something special. And many of you might not know, but I lived in Paraguay in South America for a long time. So in Thanksgiving, my family tradition is to do a Paraguayan barbecue, which means there is no turkey, there is no gravy, there is nothing that people associate with Thanksgiving, but there's a lot of meat and a lot of corn-based products. So that's what I will be eating this Thanksgiving once again.
Awesome. That's cool. I like that.
Okay. I was going to ask a food question too, but I'm going to deviate a little bit here. We've asked this question before, but I always like this question. If you could have a dinner with any either fictional character, real character, personal person in life, dead or alive, anybody, have dinner with, who would you have dinner with?
I would probably, if it's somebody who's dead, I
It could
would
be dead or
say
alive. Yep.
I would say it would be Marcus Aurelius, who was a
Oh,
philosopher and emperor of the Roman Empire at the peak of the Roman Empire, and has been, I would say, probably my most important mentor. He wrote a journal called Meditations, which is a book that I read every year. And it's just a humble reminder that if a man who had so much power and so much around him could be so humble and do
hmm.
so much good, maybe somebody like me should try a little bit harder.
Interesting.
So, yeah.
I'll tell you a funny story, Sergio. My youngest brother's name is Mark. And my grandmother was she was a English teacher, but just very like historian and just really involved. And she always called him Marcus Aurelius, always. And we grew up calling him Marcus Aurelius. And it took till I was high school to even understand that was a real person. I thought it was just a name, like a nickname she had made up. But I never really knew the full background. I'd love to hear about that book a little bit more.
Absolutely. So maybe as a second best, I can have dinner with your brother.
Yes. I don't know
There
if
you
he's
go.
as cool as Marcus Aurelius. Sorry, Mark. But he does live in Alaska and does some really amazing things for the world. So yes, we'll give him that much. Okay, Ape, up to you.
Perfect.
All right. If you could have any superpower for one day, what would it be and why?
I think I would probably like to be invisible.
Okay.
Just
Ooh.
to be able to hear what people really think and what people really say. I think that would be an interesting superpower, and it also it reminds me like have people have always taught me to always act like your mom is watching you, right?
Yes. Yes.
And I think that would be an interesting superpower for sure.
It also
Yeah, it
helps
would be
with your
interesting.
kids. If you're invisible around your kids, then they can't ask you questions. That helps me.
Yep.
Just kidding. Okay, so my final question is, if you could time travel to any era just for a day, where would you go
I think I
and
would
why?
I would go to meet Marcus Aurelius. I really would. I
Same
mean, I
thing.
would I would go and have dinner with him for
Nice.
sure.
Nice.
And I
Okay.
think what's interesting about him is also one of the things that I think you see it in many other examples, right? Where people are faith-based or people really read Western or Eastern philosophy, is that themes that seem to be true are timeless, right?
Mm,
So what's really important about life, you could learn 2,000 years ago. And
yeah,
and that's where I think I would go to the past, not to the future.
I agreed. I like
Yeah,
that.
I don't want to go to the future and know what's going to happen. I just want to find out as it comes.
Well, the past is prediction for the future anyway, right?
Yeah,
So,
Yep.
it's true.
if you understand that, then maybe we can understand where we are a little bit more. Very, very good. Very cerebral. I love that. All right, Abe,
Yeah.
let's break in.
All right. So this month is COPD Awareness Month. So that's chronic obstructive pulmonary disease. And so this is a disease that impacts so many people in the world. And so we wanted to bring Sergio in. He's an intensive care physician with us here at Sound, which in the ICU, one of the things that they really deal with is COPD. So we thought we would bring him in here to just talk about this disease a little bit more. Hopefully, we can have our listeners learn a little bit, get your perspective as well, Sergio. So, if we could start by you telling us just a little bit about you and your story.
Yeah. So I'm trained in internal medicine and critical care. I started in the academic world, ran a training fellowship program for critical care physicians in the East Coast for many years. I um, had a small animal lab. I would do echocardiograms on
Oh,
septic
wow.
mice. I had a mice ICU. Did a lot of the
Wow.
academic stuff. And then I became the hospital asked me to be trained in Lean Six Sigma, and I started thinking about how to change care at the bedside at a large scale. And at that time, I joined Steve Matchett, our CEO in critical care, came to Houston, started a program,
Mm.
and literally 2 months later, we were part of Sound Physicians, and I became the CMO for critical care, and that's what I've been doing for the last 10 years, and really trying to have an impact on on patients that I'm not taking care of by trying to improve what we do at the bedside or by bringing better to the bedside.
Awesome.
Like, I do want to ask a little off question. Sergio has a podcast, I think I mentioned earlier, but Sergio, please feel free to tell us about your podcast and what you talk about in Critical Matters.
Thanks, Alicia. So as part of my job as CMO for critical care, one of my goals was to provide professional development for our clinicians. And that obviously includes a lot of the leadership development that Sound does for its colleagues. But I also felt that there was a need for doing something clinically for our critical care APPs and physicians. So I started consuming podcasts several years ago, and I thought that it was just the perfect medium
Mm-hmm.
to share clinical knowledge. So I would say that in 2018, I want to say, we started the podcast, and it was very like let's just do it, and the marketing team was super helpful. And since then, we've done over 130, 140 episodes. Really have
Wow.
a very nice following outside of Sound Critical Care. But Critical Matters is a clinical podcast mostly. It really focuses on a broad range of topics that are relevant to the practice of critical care. It
Mm-hmm.
obviously focuses on providing clinical updates for our physicians and APPs who do critical care. But I find that a lot of the topics obviously are interesting for our hospitalist clinicians, for our anesthesia clinicians, for our emergency medicine clinicians, and many are also, I think, of general interest for all our colleagues. So really that is kind of the genesis and the focus of the podcast. And it's been a lot of fun. I mean, I would imagine that you would agree that doing a
Mm-hmm.
podcast, the biggest benefit is for the people who do it, right? You get to meet a lot of cool people, learn from other people, and it just keeps you always curious. So it's been a big plus for me for sure.
Yeah.
I love, yeah. And I would say that we definitely learned from you during COVID. That's where I learned about your podcast was I think around that time, right in 2020. And you were doing updates for the organization as well, but I think definitely things took flight and you were my first go-to for updates. So thank you
Well,
for that. But
thank you.
what you intended your podcast to do, it did, at least, from my perspective. So that's really awesome. Um, Getting back into the concept of COPD, this being COPD Awareness Month, can you just tell us, a listening audience, what exactly is COPD and what's the prevalence? Any information, just general information around
Yeah,
COPD?
for sure. So COPD stands for chronic obstructive pulmonary disease, and it's really a conglomerate of different presentations. But the bottom line is that it's a progressive lung disease that is characterized by airflow limitation. So it becomes very hard to breathe. And even though we're still trying to understand what really causes it, the idea as of now is that long-term exposure to irritants, the most common being cigarette smoke, but there's others like air pollution, occupational dust, and
Mm-hmm.
other things, cause inflammation, chronic inflammation of the airways. And over time, it leads to a series of different presentations. People may have heard terms like emphysema, which is when parts of of the lung break down, or chronic bronchitis, which is the old uncle or aunt who's always coughing, right? And
Mm-hmm.
they were smokers. So really, it's a range of presentations, but it's a big deal because globally it affects over 380 million people.
Wow.
I don't
That's
think
a
people
lot.
are aware, but COPD is the third leading cause of death in the world.
Wow.
So it's up there, right? And that's why, like April mentioned earlier, as hospitalists, as emergency physicians, and APPs, and as people who work in the ICU, we see a lot of COPD. Here in the United States, it's estimated that 16 million people, so 16 million have COPD. There's probably a
Mm.
lot more that are undiagnosed, But the best numbers that I have found in terms of prevalence is that 6% of the adult population in the United States has COPD. So
Yeah,
Wow.
it's a real issue.
Wow.
it is. I mean, yeah, just thinking of my, clinical time, like we've treated so many patients with COPD, and it was just, I remember it's always so frustrating for them because they want to get better and they want to go home, but we can't rush the lungs, right? So they want to get off that oxygen to go home, but you can't make it go any faster. So,
Yeah, for sure.
okay. Well, and speaking of that, treatment of it. So what are the mainstays of treatment for COPD and how has that treatment evolved over time?
So that's a great question. I think that when we think of COPD, there's three big things that we focus on. Controlling the symptoms, and usually people get diagnosed with COPD because they have symptoms. Number two is, like we said, it's a chronic and progressive disease, so slowing the disease progression is super important. And for those who smoke, that's the most important thing to do, is stop smoking, obviously. And the third, which I think is something that maybe in the ICU we don't think as much, but I think as healers and as clinicians, we should always have first of mind, which is improving quality of life, right?
Yeah.
Not being able to breathe or being short of breath can limit the quality of your life. So what can we do to improve that? And really, there's not that much out there, to be honest. There's bronchodilators that can be either short acting or long acting, and those are medications that usually you inhale, and they will relax the airway muscles, so it will make the airflow a little bit easier. It's very similar to what some people use for asthma, right? Which is similar but a different disease. There's also corticosteroids, which help reduce that inflammation, and you can either inhale those chronically as something that you use for maintenance, or when people become very sick and are in the ICU, you might get them either orally or through your veins. Then there's also inhalers that can combine bronchodilators and steroids. So those are used more like long-term as outpatient. You mentioned, April, that when these patients are in the hospital, often they will need oxygen. Well, some of them that have advanced disease need oxygen at home,
Yeah.
right? So there's also oxygen therapy, and that's for the people with more severe problems with oxygen. And then a final category, which is super important in trying to improve the quality of life, is pulmonary rehabilitation. And there is very good evidence to suggest that those patients who are exposed to pulmonary rehab programs will have better symptom control, will have better quality of life. And it's about improving your breathing techniques and also improving your exercise tolerance. For some of these patients, maybe even just walking a block is an enormous hurdle. So anything that we can do to improve that is going to be more important. In terms of the second part of your question, which is how has treatment evolved over time, I would say that we have become it used to be just very general. Let's just blast people with this, blast them with that. Now I think it's much more targeted, trying to understand individually what is the issues that we need to treat in that individual patient. So it's more personalized care. I also think that there's a lot more emphasis on lifestyle modification. And finally, there's a lot more emphasis on comprehensive COPD management, right? Having a team. It's not just having a lung doctor. There's a lot more than that, right? The primary
Right.
care doctor, I mean, the people involved in the pulmonary rehab, the people involved in the pulmonary clinic. Some people also even might need, I mean, psychological support, right? But having much more of a multidisciplinary team approach, which I think is something that at Sound we have always believed and learned, that the team approach, right, with different backgrounds, different disciplines, working around a patient is the way to go.
Yeah, I like that. That makes sense.
Yeah, I was just thinking, going way back, maybe 2004, 2005. I don't know if you guys remember the terms like pink puffers, blue bloaters. That's how
Yes.
we were introduced to COPD. One of the parts of many of those didactic classes was talking really about our first line use being oxygen, but overusing oxygen, right? Like there is a balance in our use with this disease. So can you tell us a little bit about that? Why is oxygen balance important, and what's our risk if we overuse oxygen with
For
this?
sure. That's a great point, Alicia. And really, it's important to emphasize that oxygen therapy can be life-saving for people with COPD, no question about it. But like you said, it can also cause harm.
Hmm.
And I think that that is true for so many things in life, right? More is not always better. And what we see with a lot of therapies is what's described as a U shape, which means that you can decrease the risk or improve things, right? But then if you overdo it, you start getting into trouble again. And with COPD specifically, the key with oxygen is that the patients with COPD are likely to retain carbon dioxide,
Hmm.
right? And if you give somebody too much oxygen for different mechanisms, it might exacerbate the retention of carbon dioxide. And if your carbon dioxide or your CO2 goes too high, you start becoming sleepy, lethargic,
Hmm.
you can go into cardiac arrest. It can definitely kill you. So that
Hmm.
is why when we see somebody with COPD where they go home on oxygen or they are in the hospital, we don't need to crank that oxygen all the way up and make sure that their oxygen is like 100% saturation, which is something that we measure. But really, the target for a COPD patient is around 88 to 92 of what's called a pulse oximeter
Hmm.
saturation. And we have to find that sweet spot where we are alleviating the low oxygen without causing danger or putting them at danger of increasing their carbon dioxide, which would also be very, very difficult. So studies have shown over and over again that if your oxygen levels are too low, you get in trouble. But if you get too much oxygen and your oxygen levels are too high with COPD, you can also get in trouble.
Yeah.
I think that's good pointing out too. I think we always think like maybe layperson would look at my pulse ox and go 92. I need more. I need more.
Yeah,
That's not always the solution. So that's great clarification. Thank you for that.
for
Yeah.
sure.
Well, we've already talked a little bit earlier in the episode about, fall weather and things are getting cooler outside. So, and this can sometimes really impact our COPD patients. So, what would you say are the most common triggers for exacerbations of COPD during these winter months?
Yep. So definitely we're coming into the winter months, and obviously everybody by experience knows that there's a lot more respiratory diseases during the winter months. Winter can be particularly challenging for people with COPD, mostly due to cold air and increased exposure to infections. So in terms of triggers for COPD flare-ups, number one, respiratory infections. And flu, a cold, pneumonia, all of those are important. Number two, cold, dry air can irritate the airways. So that is
Yeah.
also a problem,
Yeah.
right? So we've all, if anybody has run, like, I mean, in the snow, you know how that can, even in people who have no lung disease, can
Hmm.
can irritate your airways and give you what we call a bit of bronchoconstriction. The third thing that I would tell people to be careful with is that we're much more likely, especially where there's cold weather, to be indoors a lot. So indoor air pollutants such as dust or mold are also a very important exacerbator during the winter months. And finally, during the winter months, especially in areas that are very cold, people are likely to have decreased physical activity, right? So
Yeah.
that also can weaken lung function. And all of these are triggers that compound each other and make it much more likely for people with COPD to end up in the hospital during the winter.
Great. So, Sergio, when they get to the hospital, when is that step where they go to the ICU? When might someone with COPD need to go to an ICU, and really, what should families expect when that
Yeah.
happens?
So I think that we'll talk about the ICU, but what I would say first is any patient with COPD who is having an increase in their shortness of breath that does not improve with their regular medications
Hmm.
should call their primary care clinician. They should be in touch with somebody. Sometimes with just some modifications and some outpatient therapy, you can avoid coming to the hospital. Anybody who notes that a COPD family member or friend is not thinking clearly, might be slightly confused, needs to go to the hospital. Anybody who all of a sudden has blue lips and fingertips, right, might be needing more oxygen. Chest pain or rapid heart rate in people with COPD should also prompt immediate medical attention. And then anybody who has fever or is having a change and an increase in their coughing. Either now they're coughing a lot more, or they're producing more sputum. All those are I think are alarm signs that you should seek medical attention, right? Now, if you go to the hospital or you go to see your primary care clinician, often they might just give you some medication and you'll be able to be treated at home. However, sometimes you might need to be admitted to the hospital for more severe cases. And if you need support for your breathing that is beyond just oxygen, you probably will end up in the intensive care unit. And you might either get what's called a non-invasive ventilator, which is what people know as BiPAP or CPAP. It's that mask that's fitted very tightly that is commonly used for COPD flare-ups. There are other modalities, and then sometimes people might require more than that and might be intubated and put on a breathing machine called a mechanical ventilator. Other reasons why you might come into the ICU is because you have an arrhythmia, your heart rate is uncontrolled. There are some very fast heart rates that are commonly associated with COPD that might require treatment in the ICU. Patients with COPD are very prone to getting pneumonia. So a pneumonia that is very severe and impacts your blood pressure, for example, or makes you confused, you might end up in the ICU. So those are all common reasons why patients with COPD end up in the ICU. And being 6% of the adult population, I would say that it's very common to any day you're in the ICU to have patients in the ICU who have COPD, right? So it's something that we see a lot. In terms of what patients and families should expect, well, anytime somebody comes to the ICU, obviously, if it's not a planned admission, which is usually after some types of surgery, you're obviously at high risk of having complications. So you're sick, right? With COPD, I think the frequency of hospital admissions, the frequency of ICU admissions are usually associated with how advanced the disease is. So obviously, it's something that some people might be very used to going to the hospital, maybe even going to the ICU, and they might be pros as patients, but there is an inherent risk for that patient that is real, and I think patients and families should be aware of that. But the hope is that with treatment, most of these patients will be able to return to where they were and leave the hospital. But it is a common reason for admission to the ICU.
Yeah. Do you think that there's a correlation between, how long they end up staying and, how long they've had the disease? Like, as the disease gets worse, do you think the length of stay in the hospital is long? I just, keep thinking about my patients who, wanted to go home on day 2 and we just couldn't send them home yet. So
yeah, for sure. So I think that there is, in general, the longer you've had the disease, the more likely it is to have progressed and to be more advanced, right? So you have less lung function. That will definitely make whatever happens to you more severe, but also, like you mentioned, April, will make the recovery much slower. So yes. And then the other thing that I think is a reality, which we see all the time in our patients in the hospital, is that patients with COPD usually have other problems, right? And if they've had COPD for many years, it's very likely they have other problems for many years, whether it be diabetes or be heart disease. So all these things, I think, compound the impact on the patient and make them sicker, but also make the recovery a lot slower. So for sure.
Yeah. Well, we talked about the increase in respiratory infections and kind of this time of the year. So what do you think is the best steps that people can try to prevent getting these infections and worsening their COPD during this time of the year?
Yeah, I think obviously prevention is always better than treatment. And there is no question from a scientific standpoint that first and foremost, the one thing people can do to prevent infections if they have COPD is vaccinations. And this is not something that's up for dispute. Getting a yearly flu vaccine and getting the pneumococcal vaccination have been demonstrated in large studies over and over again to reduce the incidence of hospitalization, of pneumonia, and of COPD exacerbations by up to 70%. That's 70. So I would say that if you have COPD or if your loved one has COPD, you have to get your vaccines every year for flu and for the pneumovax, the pneumonia vaccine. no question that that is the most important thing. Now, if COVID vaccines are also
Hmm.
associated with that, we don't have the same level of data, but I would say that yes, get your annual COVID vaccines as well. Anything that we can do from a vaccine perspective to reduce the severity and the incidence of
Right.
infections, respiratory infections, will have a real impact on our patients with COPD. What are other things that you can do? Well, I think that avoiding crowds, especially in closed spaces if you can, and avoiding sick individuals, right? I think that one of the things that we have learned is that, yeah, influenza and colds do transmit from one person to another. So if you have severe COPD, you have to be more careful. You probably have to be much more vigilant with regular hand washing. And I know that there's been a lot of back and forth in terms of what people feel about masks. But for people with COPD in the winter, if you're taking a plane or if you're going to be around a lot of people, I would use a mask for sure. I
Right.
mean, I
Right.
think
Yeah.
that I don't care what people say, but in that instance, I think it does make a big difference because your risk is so much higher. Other things you can do are staying physically active, in right where you're indoors to maintain lung function. So I think we tend to undervalue how just walking can make an impact on our health, right? So really try to avoid being a couch potato during the winter. Walk a little bit, right? Do as much as you can to be physically active. And then we talked about indoor pollutants being an important aspect of exacerbations during the winter. So obviously, doing things to maintain your indoor humidity levels and reduce airway irritation is also very important. So being mindful of your environment at your home. Now, obviously, unfortunately for many of our patients, that is a luxury, right?
Yeah.
Uh, but I think it's important to do the best we can to have an indoor um, safe level of humidity and trying to reduce um, polluted air that can cause irritation. I recently saw a patient who had terrible lungs on CT and she never smoked. And we're all like perplexed, right?
Wow.
I mean, and then we found out that her and for many, many, many years, she would cook with wood. So the amount of
Oh,
smoke
wow.
that would generate, like
Oh,
our
yeah.
daily cooking was with wood and coal. So for years, she was exposed to all sorts of irritants, and that is what caused her COPD.
Wow.
Wow.
Wow. I feel like I could talk about this forever, Sergio. Um, but I know we're running out of time. Any closing thoughts here on COPD? Any questions you weren't asked, or any just thoughts you have in general that you'd like to share on this subject?
No, I think that the important thing is that I think a lot of people have heard the term COPD, and it
Hmm.
can be a very scary label. The reality is that the range of symptoms and severity is very, very, very broad, right?
Hmm.
I think that people who have COPD or who have symptoms should try to get diagnosed because the earlier you get appropriate therapy, the more likely you're going to have better symptom control, slowing of the progression of the disease, and better quality of life. This is a
Hmm.
chronic disease. There is no cure, right?
Right.
So it's about controlling it. I think that there's no question that one of the greatest drivers of COPD is tobacco and
Yeah.
smoking, right? And whether that be firsthand smoking or secondhand exposure to smoke. And you also can see today that um, populations that are more likely to smoke still have more COPD. So
Hmm.
again, I mean, I think that I know for people who smoke, sometimes stop smoking is difficult, but from a health perspective, it's important to try, right?
Well,
And
Sergio, quick question there. Sorry to interrupt, but vaping, it's one thing we didn't touch.
Yeah.
Are you seeing vaping
yeah,
affect
so it's
this as well?
interesting because I don't think that we have good data on vaping for COPD because nobody's been vaping for 20 years,
Right.
right? But uh, anything that you inhale has the potential of causing irritation to the lungs in ways that we don't fully understand.
Got it.
I do believe that vaping is probably less damaging as far as we know than smoking.
Hmm.
However, I think it's more addictive because of the amount of nicotine.
Nicotine content. Yeah.
And what's very interesting is that we are seeing more and more lung pathology in younger patients.
Yes.
So it clearly can cause damage, right?
Yeah. Quicker.
And I think that again, I'm not minimizing how hard it is to stop using these substances because they are addictive. I mean, nicotine is no different than caffeine. It's a
Correct.
chemical substance that we create an addiction to, right? For those who drink coffee, like myself, it's very hard to just stop taking coffee, right? I mean, it's no different, right? It's no different. I mean, just that maybe the impact on the body is better known, right? But yeah, I do think that vaping probably still a question mark in terms of COPD. We'll probably know more in the future, but yeah, it is associated with lung damage for sure. And we see young people who've come with very, very, very severe lung disease to the ICU, and it's probably due to vaping.
It's unfortunate. Well, I know if you don't listen to Sergio's podcast, one thing he loves to do at the end, especially interviews, is talk about what book you're reading. So I wanted to ask you, what book are you reading? And tell us, and it can't be Marcus Aurelius. Tell me a different book.
For sure.
That
So
you're
actually,
reading.
I'm about to finish a book called Red Helicopter.
Okay.
And it's by a gentleman called James Rhee, who is like one of these very educated private equity guys who eventually figured out he wanted to do something better with his life. So he actually took over Ashley Stewart, which I think is a clothing company that was broke and that focuses on creating clothing for plus size Black women. And through kindness and math, he made that company into a rock star, superstar of the world. And it is a fascinating book because it has a lot of themes about immigrants, about belonging, but also about how you can be very successful in any business if you obviously create a culture of kindness, but also apply math, which is common sense, right? Things need to add up at the end. And I really found it very refreshing, and I would recommend it to anybody. I think it's very interesting. I think there's a lot of lessons to be learned there.
Again, what's the book name, Sergio?
Red Helicopter.
Who's the author?
James Rhee. That's James and then Rhee.
Okay. Yeah.
I'll have to check
And
it
he
out.
also has a TED Talk that became viral about his experience with his company. So I think people can also check out the TED Talk.
I love
All
that.
right. Cool. Well, thank you for joining us today, Sergio. It was great to get to talk with you and learn a little bit from you. And to our audience, thank you for joining us today. As always, we would love to hear your feedback. If you have any suggestions on upcoming topics, or if you have any questions for us, you can reach us at our email, which is oncallpodcast@soundphysicians.com. We're also on Instagram, and our handle is OnCall with April and Alicia. And so thanks for joining us.
Yep. And until the next time, guys, you stay well, and we will stay on call. Thank you, guys.
Bye, everyone.
Thanks.